My name is Kevin Chen, and along with my colleagues Gary Gallagher and Eva Feldman, in this presentation we will discuss a general overview of the peripheral nervous system and peripheral neuropathies. This topic is quite large and many texts have been written, but in this chapter we will only start with a general overview of the relevant topics and classifications of peripheral neuropathies. If more detailed information is needed, you may look to the text chapter, online material, or the references we have provided. Additionally, trauma and focal entrapment neuropathies are specifically covered in a separate chapter, so will not be covered here. In this chapter, we will first review the anatomy and physiology of the peripheral nervous system. We will focus on the general clinical evaluation of a patient presenting with peripheral neuropathy and also discuss the role of electrodiagnostic testing. Finally, we will briefly review the categories of common neuropathies and their presentation. The peripheral nervous system consists of all nervous tissue outside the confines of the dura. This includes motor, sensory, and autonomic nerves. Myelination, if present, is accomplished by Schwann cells, with a single Schwann cell per axon, and each individual axon requiring many Schwann cells for myelination. The cell bodies for motor axons reside in the ventral horn of the spinal cord. From here, axons extend continuously until their target muscle fibers to form neuromuscular junctions. Whereas a single motor neuron axon may branch and innervate multiple muscle fibers, each muscle fiber only has a single activating motor neuron. This motor neuron and its neuromuscular junctions represents a single motor unit, which is a concept we will use when discussing electromyography below. The primary cell bodies for somatic sensation reside within the dorsal root ganglia. These pseudo-unipolar neurons send axons to peripheral signal transduction organs that detect peripheral sensations such as vibration, pressure, temperature, pain, etc. Autonomic nerves are also an important component of the peripheral nervous system. Sympathetic first-order preganglionic neurons reside in the anteromediolateral column of the thoracic spinal cord. These send axons that synapse on second-order neurons in the paraspinal sympathetic trunk or the splanchnic ganglia. Parasympathetic first-order preganglionic neurons, on the other hand, begin in the brainstem or the sacral spinal cord. These then travel to various ganglia closely related to the target organs. There are two common classifications used to describe nerve fibers and their physiology. The Erlanger-Gasser classification is largely based on conduction velocity, whereas Lloyd-Chang classification applies to afferent fibers only and links fiber type to receptor organ type. This table details the various nerve types and their properties. The fastest fibers are A fibers or type 1 and 2 fibers, which are large caliber myelinated fibers. These are the most readily evaluated on nerve conduction studies, as described later. On the other hand, C fibers or type 4 fibers are the smaller non-myelinated fibers and conduct the slowest. Given the extremely broad range of diseases that can affect the peripheral nervous system, clinical evaluation relies heavily on the history and exam to narrow the differential diagnosis. First, evaluation of whether motor, sensory, or autonomic symptoms are present can help rule in or rule out pathologic processes. Spatial distribution is also a critical component. One should get a sense of whether symptoms are symmetric, whether distal or proximal limbs are involved, whether upper or lower limbs are preferentially affected, and if whether a single nerve distribution is involved in a mononeuropathy versus many nerves in a mononeuropathy multiplex or polyneuropathy. Equally important is the temporal evolution of symptoms, whether symptoms progress over a matter of days and weeks or over months and years. The tempo of symptoms, whether steadily progressing or relapsing and remitting, can also be informative. The physical exam then focuses on the various sensory and motor modalities and reflexes. The history and exam is reinforced by electrodiagnostic studies, which provide objective and standardized measurements for both diagnosis and monitoring. Electrodiagnostics consist of nerve conduction studies and needle EMG. Nerve conduction studies utilize sensory nerve action potentials, or SNAPs, to study the course of a sensory nerve, as well as compound muscle action potentials, or CMAPs, to evaluate motor nerves and the neuromuscular junction. These permit evaluation of myelin sheaths and underlying axons within a nerve. Further details on performing electrodiagnostics can be found in the video that accompanies this chapter. If axons are solely affected but myelin sheaths are preserved, the velocity of conduction is unaffected in nerve conduction studies. However, the electrical amplitude of the SNAP and CMAP are reduced. By contrast, pure uniform myelinopathies slow the conduction velocity, but if the underlying axons are preserved, the electrical amplitude is unchanged. Hereditary neuropathies can present in this manner. If demyelination is irregular and heterogeneous, each axon experiences irregular and inconsistent slowing of the action potential. This uncoordinated response is picked up on the recording electrodes, and the signals can temporally cancel each other out. This is noted on nerve conduction studies as temporal dispersion. Metabolic and immune conditions that chiefly affect myelin can produce this pattern. Nerve conduction studies are supplemented by needle EMG directed at affected muscles based on the history and exam. First, on insertion of the needle, brief mechanical irritation is seen, but this should immediately subside with the patient at rest. Increased or prolonged insertional activity suggests early motor denervation. At rest, the EMG should be quiet. Detection of fibrillations indicate disruption of axons and their neuromuscular junctions. One may also note complex repetitive discharges or cramp discharges in long-standing neuropathies. After observation at rest, the patient is asked to gently activate the target muscle until a single motor unit action potential can be seen. With neuropathies over 2 to 6 months, lost axons may be in various stages of regeneration, and neighboring axons may sprout new endings to take over diseased neuromuscular junctions. This produces motor unit action potentials of reduced amplitude or polyphasic motor unit action potentials. More chronic or hereditary neuropathies permit maturation of new neuromuscular junctions. In these circumstances, since a single motor neuron has compensated for axonal loss and taken over a greater number of muscle fibers, motor units are few but of higher amplitude. Based on history, exam, and electrodiagnostics, laboratory studies may help confirm a diagnosis. The workup of the most common presenting pattern, chronic, symmetric, distal, sensory-predominant polyneuropathy, begins with a set of evidence-based guidelines for blood glucose, 2-hour glucose tolerance testing, vitamin B12, methylmalonic acid, homocysteine, and serum protein immunofixation electrophoresis. Genetic screening can help in cases where hereditary disorders are suspected. Although MR neurography is rapidly advancing, it is not widely available and utility is currently limited. MRI may help to identify inflammation in nerves or plexus, nerve tumors, or structural spine lesions that may mimic peripheral neuropathies. Skin biopsy may be helpful to evaluate small unmyelinated nerve fibers that are not easily studied with electrodiagnostics, and nerve biopsy, while invasive, may help confirm a diagnosis before starting immunosuppressive or cytotoxic therapies. A useful algorithm summarizes the workup we have discussed thus far. For the most common presentation, a distal symmetric polyneuropathy, evaluation begins with the history. This is focused on location, time frame, symmetry, and the modalities affected. The history is reinforced by a detailed neurologic exam. The clinician is then attuned to the presence of any atypical features such as asymmetry, non-length dependence, motor predominant symptoms, acute or subacute symptoms, or autonomic predominance. If no atypical features are present, an initial workup consists of laboratory studies which may readily reveal a cause. MRI is often used at this stage to rule in or rule out structural lesions. However, atypical features may prompt further evaluation with electrodiagnostic studies and consultation with a neurologist. At this stage, we will review some common categories of neuropathies. This review will be quite superficial, but will provide at least a framework to consider the various pathologic processes that may cause peripheral neuropathy. One of the most common neuropathies in the developed world are neuropathies related to diabetes, impaired glucose tolerance, obesity, and hyperlipidemia. These present as distal symmetric polyneuropathies predominantly affecting small fiber sensory nerves, although autonomic nerves and large fibers can be affected as diseases progress. Therapy is directed at blood glucose and lipid control. Symptom control can also be achieved with anticonvulsants and antidepressants as well as other medications. Another metabolic type neuropathy is seen with chronic renal failure and uremia, which presents similarly to diabetic peripheral neuropathy. Progression can often be halted with dialysis or in some cases renal transplant. Another large category of peripheral neuropathies are those that involve dysfunction of the immune system. A notable syndrome is that of acute inflammatory demyelinating polyneuropathy, AIDP or Guillain-Barré syndrome. This presents as a rapidly progressive, symmetrical motor neuropathy, typically starting in the lower extremities with ascending weakness. This is a purely demyelinating disease. CSF studies show elevated protein but relatively normal white count, termed albuminocytologic dissociation. Treatment involves supportive therapy, particularly if respiratory muscles become involved. Plasma exchange and IVIG can be considered, but corticosteroids are shown not to be effective. A similar immune-mediated syndrome is chronic inflammatory demyelinating polyneuropathy, or CIDP. As the name implies, it presents similarly to AIDP, but over a longer time period. In this case, prednisone is indicated, as well as plasma exchange or IVIG for severe cases. Neuropathy can also be closely associated with vasculitis. These can present as asymmetrical polyneuropathies or a mononeuropathy multiplex. Symptoms are often painful sensory symptoms and can involve motor symptoms as well. Often presenting with a stepwise progression, axonal loss is seen on electrodiagnostics. Since glucocorticoids and even cytotoxic therapy is considered, diagnosis is often confirmed with a nerve biopsy. Given the structural and metabolic demands of the peripheral nervous system, there are many hereditary diseases that manifest chiefly as neuropathies. The most common diagnosis is Charcot-Marie-Tooth disease. Although there are many subtypes, type 1 CMT presents as a distal symmetric motor predominant neuropathy. This begins in the lower extremities, with muscle reorganization producing the inverted champagne bottle legs, and can progress to involve upper extremities as well. Electrodiagnostics show a purely demyelinating pattern, with no conduction block or temporal dispersion given the diffuse and chronic nature of the disease. Other types of Charcot-Marie-Tooth are subclassified based on presence or absence of axonal loss, onset in infancy, or autosomal recessive inheritance, as well as any identified genetic mutations. It can be important to consider infectious causes for neuropathy, and globally, these account for the largest proportion of peripheral neuropathies. Causative agents include organisms associated with leprosy, Lyme disease, Chagas disease, and HIV or HTLV. Importantly to consider, some antiretrovirals can also produce a neuropathy as a pharmacologic side effect. Another very large category of peripheral neuropathies include those related to environmental or toxic causes. Many vitamin and nutritional deficiencies affect nerves first given their high metabolic demand. Exposure to toxins such as ethanol, methanol, nitrous oxide, lead, arsenic, and heavy metals can produce a variety of patterns of neuropathy. Biological toxins such as tetrodotoxin, ciguatoxin, saxitoxin, tuladotoxin, and others may be considered depending on the history obtained. And an extensive list of chemicals and pharmaceuticals can produce peripheral neuropathy with prolonged exposure. A final type of neuropathy to consider is that associated with critical illness. This is often seen in patients who have a prolonged ICU stay and ventilator dependence. Diffuse motor and sensory loss is seen, and workup is often initiated when patients exhibit difficulty weaning from the ventilator. Electrodiagnostics reveal loss in sensory and motor axons without a significant component of demyelination. After considering all of the above categories of peripheral neuropathy, the clinician must also be aware of mimics that may masquerade as a neuropathy. Amyotrophic lateral sclerosis often presents with fasciculations and motor weakness, but the lack of sensory involvement should raise a red flag. Conditions like transverse myelitis and multiple sclerosis, and even spinal cord compression and compressive myelopathy may initially raise suspicion for peripheral neuropathy instead. Imaging can help rule out these conditions. Finally, diseases of the neuromuscular junction and myopathies may also be considered as alternate diagnoses, suspicion which may be raised on electrodiagnostic testing. In summary, peripheral neuropathies encompass a broad and diverse range of presentations and pathologies. Here, we have provided the fundamentals for beginning a clinical evaluation with emphasis on history and examination. Electrodiagnostics form a critical component to help classify the parts of the peripheral nervous system that are involved, and supplemental studies may help confirm or deny purported diagnoses. For further details, please refer to the text chapter and the references.